Hello everyone, my name is Shahad Albayati. I'm a radiology resident at University of Arizona in Tucson, and today I'm going to talk about spectrum of MR imaging in complicated choledochal cysts. No conflicts of interest to disclose. So I'll talk about MR imaging approach for Todani classification of bile duct cyst and the different complications of choledochal cyst. We'll start with a quick background. Choledochal cysts are basically congenital anomalies of the intrahepatic and extrahepatic bile ducts or both. We use this classification system, which is 5 categories, to classify these cysts. Type 1 is fusiform dilatation of the common bile duct. Type 2 is saccular diverticulum of the common bile duct, which is a true diverticulum. Type 3 is dilatation of the intramural portion, the most distal part of the common bile duct. We also call it choledochocele. And type 4 is two types. There's type A and B, 4A and B. Type 4A is dilatation of both intrahepatic and extrahepatic bile ducts, and 4B is dilatation of the extrahepatic portion only. Type 5, which is also called Caroli's disease, is dilation of the intrahepatic portion only. Here is the table of the classification. So choledochal cysts are mostly present in children, but increasingly it has been diagnosed with adults who has been present with cyst complications, and the exact etiology is unclear. Some reports has been saying it's abnormal connection between common bile duct and pancreatic duct. However, this remains debatable. It's more common in Western populations and more common in females than males. It presents with abdominal pain, jaundice, and palpable mass, and some patients present with simply other GI symptoms like nausea and vomiting and fever. So there are two diagnostic tools we use for diagnosis of choledochal cyst is ERCP and MRCP. ERCP, it's invasive and the sensitivity decreases in cases of recurrent inflammation and scarring. MRCP is a gold standard for diagnosis and the sensitivity is up to 90 to 100%, is non-invasive and there's no radiation. There are multiple complications of choledochal cyst. I listed them down here and I will show you cases of some of them as well. So we'll start with some cases. Here's a case of 35 years old female who presented with epigastric pain. Here there is fusiform dilatation of the mid and distal part of the common bile duct. On the dynamic images, on the arterial phase and delayed phase, there is no abnormal enhancement to suggest malignant transformation. There's also no filling defects to suggest gallstones. So this is type 1 choledochal cyst. That's another case. There is also focal segmental dilation of the extrahepatic biliary tree. Here and on the axial MRCP, there's a filling defect on the T2 fat sat images that's consistent with a gallstone. So this is type 1 choledochal cyst complicated with cholelithiasis. Type 1 choledochal cysts are the most common and account for 50 to 80% of all cysts. The optimal treatment for this type is total cystectomy and Roux-en-Y hepatococyginostomy. Another case, there's a 25 years old female presenting with abdominal pain. There's a diverticulum arising from the common bile duct and contains gallstones. There's no abnormal enhancement on the dynamic images to suggest malignant transformation, so this is type 2 choledochal cyst. Type 2 cysts account for 2% of choledochal cysts, and they're usually removed by simple excision. And another case, 49 years old female presenting with acute abdominal pain. MRI is showing focally dilated segment of the distal common bile duct above the duodenum, where the arrows are pointing at. So this is consistent with type 3 choledochal cyst, which is also called choledochocele. On the dynamic images, there is abnormal wall thickening and enhancement, so this is consistent with common bile duct cholangitis. ERCP was performed for this case, and the pathology actually demonstrated high-grade dysplasia, so the patient underwent Whipple procedure. That's another case. 33 years old male who presented with acute abdominal pain. There is cystic structure projecting along the medial wall of the second portion of the duodenum at the expected location of the major papilla. So this is type 3 choledochal cyst, choledochocele. On the spare images, which is T2 fat sat, there is enlargement and increased signal of the pancreatic head. So that's consistent with acute pancreatitis involving the pancreatic head. So this is type 3 of choledochal cysts, which accounts for 1.4 to 4.5%, and 25% of this type progress into malignancy. Another case, this is 28-year-old female with acute abdominal pain. There's fusiform biliary duct dilatation involving the common bile duct, and it's extending to involve the central right and left intrahepatic bile ducts, as you can see. So this is consistent with type 4A choledochal cyst. There are some filling defects. These are gallstones. On the dynamic images, there is diffuse enlargement and enhancement of the pancreas, and in keeping with acute on chronic pancreatitis. Another case, MR imaging is showing fusiform dilation of the common bile duct at the level of the cystic duct insertion, where the arrows are pointing at. There is no abnormal enhancement on the dynamic images, findings in keeping with type 4A choledochal cyst. Here's another case. Here there is dilatation of the extrahepatic common bile duct and both intrahepatic ducts. This is in keeping with type 4 choledochal cyst, it's type 4A, and this patient is status post laparoscopic cholecystectomy. There's no abnormal enhancement on the dynamic images to suggest malignant transformation. So type 4 cyst accounts for 15 to 35% of choledochal cysts, and it's two types, type 4A and type 4B. Type 4A includes both intrahepatic and extrahepatic duct involvement. Type 4B involves dilation of only the extrahepatic biliary tree. The treatment for type 4 choledochal cyst is debated, so it's either excision of the extrahepatic component or hepatic resection in case of unilobar disease or liver transplant in bilobar disease. Another case, this is 31-year-old female with recurrent fever. The MR images are showing extensive saccular and fusiform intrahepatic biliary duct dilatation. It's mostly pronounced in the right hepatic lobe. You can also see the cystic disease involving bilateral kidneys. So this is polycystic kidney disease, and this is called Caroli syndrome since it's a combination of both intrahepatic biliary duct dilatation and polycystic kidney disease. We call it also Caroli syndrome if it's associated with congenital hepatic fibrosis. 20% of choledochal cysts are type 5, and the malignancy in Caroli's disease is about 7 to 15%. So MR imaging and MRCP demonstrates high diagnostic performance for choledochal malformations and early detection of the cyst complications. MRI and MRCP are great and crucial for preoperative planning to delineate anatomy and to exclude malignant transformation. Thank you very much.